Good afternoon, everyone, and thank you for joining us today. If there's anything we've taken from the last 2 years, it's that health is paramount. We not only realized the importance of basic hygiene, but we also understood the importance of being in good health and building our immunity consistently. It was during these times that we grasped how important doctors and medical professionals truly are. This year, we brought you the hybrid version of the Think Again Conclave, hoping to get you to experience thoughts, innovations, and deep dives of knowledge right from the comfort of your homes. As a part of the fourth talk, this Apogee, it's my utmost pleasure to welcome our honorable guest, the Chief Scientist of the World Health Organization and former Director General of the Indian Council of Medical Research, Dr. Soumya Swaminathan. Dr. Swaminathan has essentially reached the pinnacle of medical research. Born in Chennai, she received an MBBS from the Armed Forces Medical College in Pune and an MD from AIIMS, New Delhi. A diplomate of National Board from the National Board of Examinations. She completed her postdoctorate medical fellowship in neonatology and pediatric pulmonology at the Children's Hospital, Los Angeles, at the Keck School of Medicine, USC. A research fellow, a senior research officer, an adjunct associate clinical professor, a coordinator. She was also the Director General of the Indian Council of Medical Research and Secretary of the Department of Medical Research from 2015 to 2017. Previously the Deputy Director General, she now sits as the Chief Scientist of the World Health Organization. It is incredible to have you today with us today, ma'am.
Thank you very much, Akash and Lavanya and all of the organizers of this conclave. Pleasure to be with you all.
So as a part of this session, let's start with the questions we have for you today, ma'am.
Sure.
You spent a considerable part of your research on the study of HIV and now have been actively involved to prepare the world to fight COVID for the past 2 years. Where do you think we stand in our fights, particularly against the viral diseases, which can potentially turn into epidemics or pandemics? It's widely known that that is among the most difficult problems targeted by the medical community presently. But how far have we actually reached?
That's a great question. And the answer is that we still don't know a lot or most of the viral kingdom. As you know, viruses are the most predominant of all kind of living organisms. And there are different kinds of viruses and they're able to live, very simply. They're very simple structures. And so there are viruses everywhere. Of course, we know some viruses that infect or impact humans, not all. There's a huge range of viruses in the animal kingdom. And I just saw a paper that talked about all of the viruses that they're now discovering in the marine environment, which we know even less about. And so there have been attempts in the past, things like the Global Virome Project, to try and document or start to cataloging all of the different viruses that exist, but we're far from there. So I think what is important is, of course, this is a huge area of science, clearly, and given some of the technologies we have today, like metagenomics, it makes it easier to explore, but it has to be systematic. And I think we also need to understand what these viruses are doing, and particularly how they interact with humans. That's really of interest to us in medicine, and particularly the animal environment that we live with, both the domesticated animals and wild animals, because we know that over 75% of emerging infections are going to be zoonotic infections. They're most likely going to be viruses, which means they're going to jump from an animal species into human, and we can't predict. There are about 20 odd viral families that we know are capable of infecting humans. So those are being studied in more detail. So one of the things the WHO is now trying to do is to look at prioritizing viral families that need a lot more research, and particularly targeting certain maybe species of viruses which can cause, influenza for many years has been a target of a lot of research. Now we know that coronaviruses are also very important. And similarly, there are a few other families of viruses that cause sporadic disease, but which could come back in a big way. And, some big diseases like HIV, you mentioned, also was a zoonotic infection, came from some species of primates, non-human primates in Africa, 2 different species, and jumped to humans about 50, 60 years ago. Similarly, Zika, we know of Nipah virus that we've had in Kerala, a couple of very scary outbreaks in the past few years. So there will be more in the future as well. And so I think this is an area of interest, of a lot of unknowns, or an open area for research. It's sometimes called One Health, which means you're trying to connect the animal kingdom, humans, as well as the environment, and look at it in a holistic manner.
Right. And speaking about HIV and outbreaks in general, what specifically motivated you to keep you interested in the field of HIV and tuberculosis as a young researcher?
So in a way, it was serendipity, you could say, as happens many times in people's careers. So I had trained as a pediatrician at the All India Institute of Medical Sciences. I'd done my MD. One thing is, I was always interested in research from a young age. And so after doing my MD, I felt I was not fully equipped to be a good researcher. I didn't have the skills. And so I decided to go to the US for a fellowship program. And I applied to several institutions, and I finally ended up at the Children's Hospital of Los Angeles, where I had an excellent mentor who really trained me in research methods. And I did hands-on a lot of research, both in the biomedical engineering side, as well as on the clinical side. I didn't go into the animal experiments because I've always disliked dissection and working, doing experiments on animals. That was an option. I avoided that. But anyway, coming back, I finished my fellowship in pediatric pulmonology, which is pediatric lung diseases and neonatology. I came back to India in 1991 and was essentially looking for a job where I could use my clinical skills, my teaching, as well as research. Discovered that this was not possible. It was it was a big disappointment to me at that point, because I had seen in the US how people are able to combine their clinical work and their research, and the universities allot them time to do both. However, here I had to make a choice. And so I got an opportunity to work at the Tuberculosis Research Center, which is an ICMR institute in Chennai, focused on TB. And so I started working on childhood TB, and then went into adult TB. I did some non-TB work as well in terms of research. But then came along HIV. As you know, it was around 1996 that it was first described in Chennai by Dr. Suniti Solomon and colleagues. And then after that, it was clear over the next few years from experience both in India and in Africa that tuberculosis was the major killer, the major opportunistic infection, and the thing that killed most HIV positive people. And so since I was working in a tuberculosis center, my Director General of the ICMR at that time, Professor Ganguly, came to Chennai one day and he said, "You are in a good position to set up a lab and to set up studies to do the link between HIV and TB. No one else is doing it." And so that's how I started, with a lot of encouragement from him and from my director at that time, Dr. Narayanan. And I set up not only the clinical studies, but also had to set up the lab because, we were a TB institute. So I had to set up all the HIV related, and it was not funny, but it was striking that there was so much stigma at that time that even my own colleagues did not want to work. I mean, I had to go literally person to person asking who will be in my team. And I found 6 people in an institute of, 500 that were willing and keen to work with HIV infected people, because this was before there was treatment. It was a fatal illness, it was like a death sentence once you got it. So it was terrifying, really. And a lot of people used to ask me, why, you've got a family, you've got young children, why do you want to work in this field? But I learned so much by working with this, especially in the early days when people were stigmatized, they were made to run around from place to place. There weren't too many hospitals who took care of them. There were orphaned children, widowed women, young, most of these people were very young at that when they get infected. And so I learned so much about the social, economic, behavioral aspects of medicine apart from learning about the clinical aspects, that it turned out to be a very satisfying time of my life. Both TB and HIV affect, marginalized, vulnerable communities. And so that really kind of inspired me and kept me going, because I felt that we were doing something for a group of people where not many at that time were interested. Many people say, why are you working on TB? And people in the West, in fact, think that TB was eliminated a long time ago. Say, oh, you still have TB, enough to do research on, and so on. So I realized that there's a lot more education and advocacy to be done as well. And so over, I think, a period of time, I also started understanding the importance of communicating to the general public about issues that they may not be otherwise aware of.
Your insights on this are incredibly inspirational, and your drive to remove all stigma is amazing. But we've had this question that if you weren't in medical research, what profession would you go for and why?
So my first earliest memories of what I wanted to be was to be a veterinarian, because I loved animals. And I always had pets, dogs, sometimes cats, birds, etc. And I loved to go to the vet's office and just sit there and observe. And I was fascinated. And I think I spent one whole summer holiday sitting with the vet and practicing how to give injections when I was about 12. So that was my first career choice. Later on, I also, because of my childhood experiences and exposures, I wanted to go into research, but I wanted to specifically go into genetics research, human genetics research. And there was an incident that also, I think, influenced me. And that was in class 10 or 11. I think maybe I was finishing class 10, going into 11. We had in those days the Science Talent Search Scholarship examination. I had given that exam. We were supposed to do a summer project as part of that. So I went off to Calcutta. In those days, I lived in Delhi, and worked in the lab of Professor Archana Sharma at the University of Calcutta. She's a very renowned geneticist. And this was 1974, I guess. And she took me to the hospital clinic one day, to the genetics outpatient department. And we saw a young girl who was 1 or 2 years older than me, who had been brought there by her parents because she had not attained puberty. And so she was, I met this young girl, and, she had certain features that were different, looked normal like anybody else, but if you examined closely, you could see a couple of certain characteristics. And then we took the blood, we went back to the lab, and I was tasked with doing the karyotyping, which is essentially the way to look at the chromosomes. And this is fairly crude, and this was 1974. Today, you have much more sophisticated genetic techniques. But when I did the karyotyping, it was so fascinating for me that this girl had, we all have 46 chromosomes. We have 23 pairs of chromosomes, and one pair is the sex chromosomes. This is the X and the Y. If you're a girl, you should have 2 X chromosomes. She had only 1. So the second X chromosome was missing. And this accounted for her symptoms and the lack of sexual maturation. It was like a moment where I felt, oh my God, look at the power of science. Within a few hours from this girl's blood, we have been able to find out what her problem is, and that begins the treatment. Then once you understand the cause. And that really fascinated me. And I said, I want to do genetics. So I was all set to do to go through a pure sciences, BSc, MSc, PhD career. And it was because of when I was in the pre-med in Hindu College in Delhi, all of my 100% of my classmates were appearing for the medical entrance exam. So I guess in a way, it was, again, just serendipity or peer pressure, whatever you call it. I appeared for medical entrance. And I appeared only for one medical college because in half of my mind, I still wanted to be a pure scientist. And I thought if I do one medical entrance and I'm probably not going to get in, then that solves my choice problem. I don't have to then worry. I continue with my BSc in Hindu College. I got into AFMC. And so then I ended up taking that. And my parents and others said, you could still do genetics, after you've done your MBBS. You'll probably be more tuned in onto the clinical side. So that's how I ended up in medical school. Not that I always wanted to be a doctor or anything like that. But then I still didn't give up my love for research, even though I went into medical school. And no one really spoke to us about research, I must say. So there are some gaps in medical education, I think. And in fact, in education in general, I believe, undergraduate, postgraduate education, I don't think we are exposed in India to research methods, to statistics, because that helps you, even if you're not a scientist, it helps you on how to look at data, how to evaluate something that somebody's telling you, or a paper you read, or a report you read. Once you understand the basics of statistics, it really helps in later life. So I wish we would strengthen our teaching. Maybe it is in bits that you have very good statistical training, but it's something, if you don't have, you should equip yourself with, I think, fairly early in your educational life.
Yes, ma'am, that's very accurately put. The misinformation is actually a cause of this, and that's where I go to my next question. Like during this pandemic, we saw a huge amount of misinformation spread across populations in developing and developed countries. Misinformation was primarily more in political scenarios, but why do you think that the medical world was affected so much by misinformation? And where do you think that the institutions lacked in trying to counter this problem?
So when I think about this, there are two things. One is that you talked about institutions, like let's take WHO, or let's take any of the bodies that make policies, right? Like the Centers for Disease Control in any country, or the public health agencies. They depend on knowledge and scientific data that's available. So when you're dealing with a new virus or a new entity, you have very little to go by. You have some historical knowledge of other similar viruses. Like we know, for example, we've had two previous coronaviruses that were bad. One was the SARS, and the other was the MERS, the Middle East Respiratory Syndrome. That's also a coronavirus. So we could maybe impute some learnings from those earlier experiences, but we didn't know exactly the properties of the SARS-CoV-2 at the beginning. So you have to start making guidance based on whatever information you can collect. There's some anecdotal, there's some early reports. Some of them later on proved to be incorrect. So I think the first lesson is humility. When you're dealing with an unknown, humility is very important. You cannot go around saying, I know everything about this, and what I'm telling you is 100% correct, and it can never be changed. You have to change based on evolving evidence. Now, what happens is sometimes the public can be confused or misinterpret that as saying, oh, but they said this a month ago, and now they're saying this. So they've got it all wrong, and they don't know what they're talking about. So I think this is a process. Science is a process. Science is always building one step on top of another. And science also means you accept your mistakes and correct them. And if somebody makes a strong argument with data, then you have to change your mind. Now, that's not obvious to everybody. They think scientists must know everything from day one. And what business do they have to change their mind? So that's, and for organizations also, it's very difficult. I can tell you that an organization like WHO, on which literally hundreds of millions of people depend, you're always balancing speed, the need for speed, with the need to have enough evidence. And if you keep on waiting for that data, you're too late. So there's that balance. Are you too early and you may need to change? Or are you going to keep waiting till you get enough evidence? Which we normally do in other diseases for which there isn't an emergency. We also promoted a lot of research, of course, that's true. So that helped. Now, on the public side, so organizations have some issues. The public, as I said, firstly gets confused because they've never followed the process of science before. Now, I think this pandemic has brought science to the doorstep of everybody, to the front pages of newspapers and television channels. How are people influenced? People get influenced by what their peers or their social circle is talking about, right? And this is where the misinformation comes in, because if something makes it into that through a WhatsApp group or through some videos, which, sometimes videos go viral. I can never understand why some videos go viral, but they do. And because of social media, we're facing first time a pandemic in the social media age. We have new experiences. The speed at which information and misinformation spreads around the world is amazing. And so for people, it's really confusing. You're getting a video from supposedly rational people. There are videos from people who say they're experts. They are sometimes professors here and there, but they have very different views, which are not aligned with most others working in the field. And they introduce themselves as experts, and then they talk about why vaccines are dangerous or this or that. Sometimes they use data to misinform. Data is something you can use in any way. So if you have a clinical trial and you had, let's say, 50,000 people there, and let's say 25 people had side effects, maybe one person died, maybe no one died, but somebody had a serious side effect. If you only pick on that person and say, they gave this vaccine and this person then ended up with this problem, and you forget about the fact that this vaccine is being used in hundreds of thousands or millions of people, then you can very easily confuse someone, or you can raise a doubt in someone's mind. It's enough to raise a doubt. So this is what has been happening with the misinformation. So we actually started this big program. In fact, our DG coined a word infodemic, or used the word infodemic very early in the pandemic. He said there's a pandemic due to a virus. There's also an infodemic, which is the overspreading of information, some good, some bad, makes it confusing. And so what we did is also work with some of the big tech companies like Google, like Facebook, like Instagram. And we said, how can you help us to put credible information out on your sites and reduce the amount of misinformation? And so the algorithms are trained now in a way that if you ask a question about a vaccine or about COVID, Google takes you to some credible sources of information. Facebook does the same. And sometimes we flag to them that here's a video circulating, which really is misinformation, and can you pull it down? But more than pulling down videos, what we focus on is trying to build more of proper credible information by linking. So this whole area of, again, is a new area of work. It's multidisciplinary, because you need social scientists, you need economists, you need journalists and media people, you need people, and we have something called social listening, where our communications team is all the time tuned into different social media channels, trying to pick up what are people talking about. So ultimately, we want to go to a platform, a digital platform, where different countries, people can see what the citizens are discussing in terms of health issues. And that will help the health ministries provide, because you have to address the doubts that people have. If you ignore them, you're not going to make headway. And finally, I would say that the most effective way to handle misinformation is in person, or personal touch. Long back when India was trying to eliminate polio, they faced pockets of resistance. Today, we see the same with the MMR or some vaccines, where for some reason there are pockets of resistance in a particular community. People believe that there's basically a misinformation going around there, and so they resist the vaccine. So India used, religious leaders, community leaders, they used influencers, celebrities to achieve, what was considered an unachievable task, that India could ever eliminate polio, because you had to reach every child with polio drops around the country. And we've done the same with COVID vaccination. We've had very little hesitancy in India. And where there has been hesitancy, the local authorities, the district magistrates, the collectors have taken action. They've gone and spoken to communities and addressed their issues. So that is most effective, actually, when you understand what the local issue is and try to address it, and through data and science. And again, transparency is important. Being more transparent with data actually builds confidence.
And when we speak about misinformation, this time the WHO was subject to some unfortunate skepticism due to the misleading and misinterpretation of facts. So how would you like to address the unfortunate skepticism that the WHO faced?
I think the sad thing which happened in this pandemic is that it got politicized. I mean, I think one should not be politicizing a virus which is affecting humanity as a whole is not differentiating, between countries or between people, religions, etc. It's just goes wherever it can and it spreads. Unfortunately, in some countries, not all, politics came in the way, ideology came in the way. That has really impacted those countries very badly because you find that one group of people of one political leaning are willing to take the vaccine and follow public health guidelines. Another group of people who belong to another political leaning are not. And so it is very difficult to deal with a pandemic or an epidemic in such a situation, and very unfortunate. And there's seems to be very little that one can do about it. So I think countries need to take lessons from this, what has happened, and make sure that in the future, problems like epidemics and pandemics, problems like climate change that affect everyone around the world should not be politicized. And that also these global problems need global solutions. You cannot tackle climate change by one or two countries doing things and everyone else carrying on as before. Similarly, in pandemics, when you have trade and travel restrictions, or you have vaccination programs, you need the whole world to be on the same page. Otherwise, you will continue like what's happened now with vaccine inequity. Because Africa is so under-vaccinated, the variants can continue to arise from there or from other parts. There are pockets in Europe also, in Eastern Europe, that are not well vaccinated. So if you have some parts of the world like that, then you're going to face difficulties and challenges. Similarly, as I mentioned, climate change is a big issue. Antimicrobial resistance is also an issue which will impact everyone in the world. And so we live in one planet, and that's why now we talk more about planetary health. In fact, our theme for the World Health Day on April 7th was Our Planet, Our Health.
Ma'am, as a woman in STEM, what are some differences that you've observed in the field throughout the years?
I think on the whole that it's on a positive trajectory. I would say that there's a lot more recognition now that women in STEM need to play an equally important role in decision making. I think many institutions and organizations are actively having policies to promote and support women, gender equality, and also not just women, but I think it's the diversity you need. And there are reports like the 50-50 report, the gender 50-50 report that comes out, I think once in 2 years, which looks at the composition of the leadership of top global health organizations and finds that, 90% of these organizations are headed by men from high-income countries. And even when you have women, they're from high-income countries. So there's always that. You have the low and low middle income country representation, you have women, you need the diversity in leadership in order to have strong institutions that take, different experiences and different perspectives into view and in decision making. It really, I think even companies now are moving in that direction. And so people do recognize it, but change takes time. Change is slow. I mean, if you look at something like the Royal Society, which is, I think, 400 years old, less than 10% or 11% of their fellows are women. Now they're trying to change that by actively looking for women scientists. So in terms of, I think, ambition and trying to pursue goals, women are usually a little more reticent than men. We always think that we have a lot of other responsibilities as well at home, as family caregivers of children, of elderly, etc. And we multitask, I think, a lot more. But I've also realized through my career that you also sometimes need to put yourself forward for things which men are able to do much more easily than women. I've noticed that if a certain position comes up, a woman is likely to underestimate herself compared to a man. So there's also leadership building, mentorship, etc., which can help women. But there's no reason why, because we know that there are no inherent differences between men and women in terms of capacity to do any of these things. So it's just that we've all lived in patriarchal societies, and so it takes time to overcome that. But it does need that the leadership recognize this and make an active effort. And it's not just STEM, in public life, you look at the number of women in parliaments around the world, including in India, it's still very, very low. So again, diversity, young people, women, people from communities that are not otherwise well represented. In some situations, you might want people of different sexual orientation as well to be involved. I think decision-making improves. We've seen in COVID also that decision-making was much better in places where they had a diverse committee, which was more inclusive, that listened to civil society and citizens and so on. So I think it's a trend, it's begun, but there's still a long way to go, I think, before we achieve gender equality in terms of leadership positions, particularly in STEM.
And to rephrase this question in a more national standpoint, as you're someone who's seen the global atmosphere of research, so what are some cultural shifts that you noticed in the Indian medical research scene after the approximately 4 decades you spent out of this country?
So I didn't spend 4 decades out of the country. Actually, I've spent now the last 4 years out of the country. And earlier in my career, I had 3 years in training out of the country. So in fact, I've spent my entire career in India and a lot of it in the ICMR. I see that this change because of some of the initiatives of the government as well, where the Department of Health Research has programs to support medical colleges, to set up departments of clinical research. My own alma mater, AFMC, set up a department of medical research. I've often felt that the armed forces can do much more research. In fact, most of our universities and institutions don't do enough research of high quality. And unless that's built in, you won't have the students also exposed. So for example, I see abroad in the US and Europe that children in high school, start interning in different places. It could be in a lab of somebody, or it could be in a field. That internship opportunities are so important, again, in shaping future interests and thinking and bringing out a lot of innovation. So we need to really open up our institutions to young people. And we also need to promote good research. As I said, understand research methods, statistics, building scientific literacy, health literacy in the community is also very important. You asked about how are we going to deal with future pandemics. I think unless people understand how these things come about, we can't expect them to. Similarly, for other health issues, I mean, most of our health problems for the future, the biggest risks to our health are environmental health risks like air pollution and so on, for which we need to find solutions. And technology, all of you are budding, engineers and technologists and so on. You will be able to find solutions, but those solutions then need to be adopted, and they need changes in people's behavior. That's the challenging part. It's the behavior change that is actually much more difficult than finding a technological solution. And so I think this is where we underestimate, again, the contribution of behavioral and social sciences, particularly when we're talking about these issues which need behavior change. You want people to take the bus or to cycle or to walk instead of taking a car to work. You want them to make healthier eating choices. You want people to give up smoking. If you want to reduce air pollution, there are a number of actions that need to be taken. So I think we need to come out of silos again and to have these conversations which raise problems, and then find solutions. And I think one thing that as young people, you have to be really, I know that you are, and I'm often inspired by young people's commitment to environmental issues and concerns, much more than our generation. You will find the solutions, but unfortunately, the people in decision-making positions are of a different generation, not your generation. And so we have to find ways of hearing your ideas and voices and adopting those so that we can save planet and nature before it's too long. I mean, we're just on a trajectory now that is going to lead to a huge amount of both human distress, but also probably extinction of many animal species and so on. So I would think that, and the pandemics are linked to climate change. They're all interwoven, and climate change and the impact on our health is something that most people don't realize, but it's so closely linked. And so we need to start making more, again, do more research, make more data available, and then take action. And I think every sector here has responsibility, especially the private sector has a lot of responsibility in not being extractive of nature, but really being more sustainable in how we live.
I completely agree, ma'am. And I think research in general will take a turn for the better in the coming generations. Now we have a few questions from the audience. So the first one is, what do you think is the new normal? And what's the future of COVID? As we've seen, influenza has been fatal too.
So the new normal should be something that we design to be better than, because what we've learned from COVID is that all countries were unprepared for the pandemic. We had underinvested in public health and primary healthcare, and probably underinvested in science as well. Luckily, because of the investments that had happened in R&D, we were able to deliver vaccines in 325 days, something which no one would have predicted. And that only happened because of decades of investment in mRNA and in other platforms. So investment in science pays off. And so every country needs to think about that and think about where there were gaps in the response. Like we've set up this INSACOG, which is a sequencing consortium of genomics. Now that's a wonderful initiative that can now be leveraged and built to look at other pathogens. So because now we have the sequencing capacity, we've set up the network. A lot of it is bringing the pieces together, bringing the data together, bringing the scientists together, and then analyzing. There's no dearth of data being generated in India. It's just not well synchronized, and the analyses should be used then for decision making, for policy making. So that's one whole area, is building back better, or building back in a way where we address the deficiencies of the past and look way into the future to see where are our main problems going to come from. And as I mentioned, the non-communicable diseases is probably going to be a much, much bigger problem for us and a killer. Diabetes, hypertension, lung disease, these are all going up. So we have to address the risk factors and the primary cause of this, in addition to dealing with people who get sick. Because if you don't turn the tap off, you'll never be able to build enough hospitals to look after the sick. So I think building back better is looking at the root causes of ill health and trying to move towards a society where there's wellness as the goal and not just the absence of disease. I think we also need to focus on education, because we've seen, again, the pandemic, I think one of the worst impacts it's had is on young children who've been out of school now for 2 years. And in many developing countries, schools were closed. In high-income countries, they prioritized the opening of schools. So again, there's a difference in the response between what high-income countries did and what low and middle-income countries did. So a whole generation of children is going to need help and support to catch up and to make sure that these 2 years don't become a permanent a drag or a difficulty in their future career path. So if we focus and we on health, on environment, on education, on science and technology. And when I talk about science, I talk about all sciences, and I don't mean only biomedical sciences. I consider the social sciences also to be equally important. More research, use of data, interdisciplinarity. If you look at the papers today in Science and Nature, they all have 100, 150 authors, and many of them are from different disciplines. So collaboration, both within country as well as external global collaboration, is very important. We saw that the most successful studies that were done during COVID were these large multi-country studies that provided so much of data, including the WHO Solidarity Trial. So I think our thinking has to really, as they say, think global but act local, learn the best from the global networks, but then apply them locally, find solutions which are affordable, which are sustainable, which are relevant for the context that we live in. And there's amazing work going on in India. I think I'm confident that, there's so many social entrepreneurs today that we didn't have 10 or 15 years ago. So that's what I would say is, on the new normal, on what will happen with COVID. There are a few scenarios possible. The most likely scenario is that it goes into endemicity. What do I mean by endemicity? It doesn't mean that it becomes mild or disappears. It means that it stays in the human population. Like we have other infections, we have influenza, we have respiratory viruses, we have tuberculosis, we have malaria. These are all considered endemic diseases. They kill a lot of people every year, but we can't expect to eradicate them. So in this case, luckily, we have very good vaccines, which we don't have for some of the other diseases I mentioned. And so by high vaccination coverage, we can achieve a level of population immunity that will be enough to protect most people from getting sick. You get COVID, you get a mild infection like a upper respiratory, you recover in a week. There will always be vulnerable people in the community, particularly the elderly, particularly those who have underlying illnesses which suppress the immune system. They will get sick. Some of them will get sick. Some of them will die. We will continue to see that. And we have to be prepared to reduce impact on death because we have vaccines. We also have drugs now, which of course need to be started early and so on to have an impact. And we have diagnostics. So we must continue surveillance. We mustn't be blind to what is happening. So we must continue surveillance, including genetic sequencing surveillance. We should continue to be prepared in terms of having enough oxygen in the hospitals, because oxygen is essential. It's an essential drug for all diseases, not just for COVID. And we've learned, what oxygen shortages can do. We must have the drugs. We must have trained manpower. We can use digital tools a lot now, like telehealth and telemedicine, to support people who are in distant communities. Focus on the vulnerable, I would say, the pandemic exposed inequities. In every country, the people who were most impacted were the people who were marginalized or at the lower sections of economic groups. They suffered the most in terms of deaths, in terms of, we have a lot of orphans now. There's more and more data coming that there will be after effects of COVID in terms of higher risk of cardiovascular disease, diabetes. So we need to prepare our health system to deal with that, with cognitive dysfunction. We have already aging coming in as a problem in India. So I don't want to be pessimistic, but the worst case scenario, of course, is that this COVID virus, it recombines, it changes, it evolves, it mutates in a way where it becomes completely able to overcome our immunity with the vaccines that we have today. And then we have to redo our vaccines, basically. We do that for influenza every year, by the way. We engineer we have every year a committee that sits at WHO, and twice a year they pick the strains that should go into the vaccine. We don't know if that will be needed for COVID. At this point, the vaccines are working against all the variants of concern. But in the future, we may have to change our vaccines, and we have to be ready for that. That's why the sequencing and surveillance is important. So that's a bad case scenario, but the good case scenario will be gets into a phase which is endemic, maybe has periodic surges, small surges, localized in different parts where there are still susceptible people. And whenever there is a surge in the community or increased transmission, we know that by wearing masks, we can reduce it. if everyone puts on masks, especially in an indoor setting which is poorly ventilated or in a crowded place, you can significantly reduce the transmission. So we also have some of these other tools that we know work. Attention to ventilation is going to be important. And as engineers, you would need to look at ventilation in indoor settings in our schools, in our offices, in malls and recreational places, and see, because it's not just again for COVID, but improving ventilation in buildings will help reduce the spread of other respiratory infections as well. So again, many of the things we've learned from COVID, we can use to improve our environment to deal with other respiratory infections as well. And of course, I think we should use the knowledge we've gained on the vaccine platforms to make new vaccines for diseases like TB or dengue, for which we don't have good vaccines. So the science has evolved a lot. We've learned a lot more on immunology and virology than we knew. And I think all of this is going to help. And I hope more young people will go into science now as a result of the pandemic.
Undoubtedly, our chat could go on for hours and hours. But in the interest of time, these are all the questions that we could ask. Thank you so much for taking out your time out of your busy schedule for us, ma'am, and sharing your experience and thoughts with us in the Think Again Conclave at Apogee 2022.
Thank you very much. It was a real pleasure to be with you. Thank you.
We would also like to invite everyone at the talk of Deepa Malik at 4:30 p.m. in the main auditorium. She is India's first Paralympic medalist and also an Arjuna awardee. Thank you so much.